First question. So in regards to, I think this is referring to EGFR TKIs, so osimertinib. In regards to the dose, does increasing the dose increase the efficacy of the drug? Are there any fourth generation EGFR TKIs in the works? And is amivantamab and lazertinib available if the platinum chemotherapy is not effective? So I will try to address all of them one by one. So that first question, does increasing the dose increase the efficacy? That's actually quite a tricky question. So the way that drugs are actually approved when we're doing these clinical trials is that drugs are approved at the maximally tolerated dose, which is not necessarily the maximally effective dose, meaning that we basically take the dose that is best tolerated by patients with respect to side effects, but that does give us wiggle room to decrease the dose, like we've talked about, to help improve its tolerance. I will say that in some instances, we have seen that if we increase the dose, we may get some better control of certain areas. And really in this situation, it's in patients who maybe have brain metastases that can be growing, but it's not necessary that a higher dose means that it's more effective. And so I really do try to counsel patients that it's okay to have a lower dose if that means it's more tolerable. As far as I know, I'm not aware of any fourth generation EGFR TKIs that are in clinical trials. I know that there's a lot of work in this space, but I don't know specifically of any clinical trials. Where the combination of lazertinib and amivantamab as we speak today is not yet currently FDA approved. And so the only way a patient would be able to get on the combination that I'm aware of is actually through participation on the clinical trial. As a general principle, could it perhaps be more valuable to return to a targeted therapy after someone has been on chemo for a while since the last targeted therapy? Millie, I'm going to let you take a crack at that one first.
So this is from Jack West. So I think this is a great point. And I certainly do this in clinical practice. So, when we do have patients who've been off of targeted therapy for a while and have been on chemotherapy, I do think it's worth considering going back to a targeted therapy option. And so, again, in the context of ALK, where I was talking about sort of thinking about chemotherapy after someone's progressed on lorlatinib, I think going back to perhaps a different ALK inhibitor after they've been on chemotherapy for a while, I think is a reasonable option. And so that is something that we're doing in patients with driver mutations in general, thinking about chemotherapy, giving patients time on chemotherapy, and then if we have to think about kind of a next line in therapy after a year or longer on chemotherapy, I think that's the time to consider going back. And I have seen responses to these targeted therapies again after they've been off therapy for some time. So yeah, I think that's a great point, and it's sort of a great general principle that many of us sort of put into clinical practice.
Yeah, so I can add to that as well. So I think that's a great question. It certainly would be, if a patient was on chemotherapy before I put them back on a targeted therapy, I would probably do a biopsy, whether that's tissue or blood, just making sure, we like to see that there's hints that perhaps a targeted therapy would be effective. So they have an EGFR still or an ALK still. I will say that more recently, I have seen some of my colleagues continue a patient on their targeted therapy and adding a platinum-based chemo to it. And I've done that in a few instances where I find that patients still have the EGFR mutation, but they're clearly progressing on the osimertinib. And we put them on osimertinib and the platinum doublet chemotherapy. And the rationale there for me is that the chemo is going after the more osimertinib resistant population of cancer. and the osimertinib is keeping in check those that are still what we think sensitive to the osimertinib. And then I think for me, I like to keep the drug only because it has perhaps a better efficacy against brain metastases than what we traditionally think about with chemotherapy. I can't tell you that this is, I have great data to back all of this up. I've just seen it in practice a little bit more commonly, and at least anecdotally, of a few of my patients of mine have actually been doing pretty well on that kind of a treatment plan.
And I think as a follow-up, yes, I agree that, there's a follow-up comment here about thinking about adding a different therapy against the same target, not the old one, unless there are no options. Agreed. Especially in the setting of ALK, where we have a number of different ALK inhibitors that we can think about, going to a different drug after, patients have been on chemotherapy for some time is generally what I would do. In EGFR, I will say, there are patients that maybe had progressed on osimertinib. They've had multiple lines of chemotherapy. Sometimes I would think about going back to the osimertinib. I generally wouldn't go back to one of the earlier generation TKIs. But again, trying to think about, re-challenging with osimertinib. That's generally in the setting of, patients who progress on multiple lines of chemotherapy where we don't have, other great options. In the case of ALK, it's a little bit different because we do have a number of other second and now third generation ALK TKIs that are FDA approved that we can use. For EGFR, it's a little bit different. The only third generation EGFR TKI that we have is osimertinib. So, but I think the field is evolving, and I think we're going to have more options moving forward.
Absolutely, I agree.